All right, so welcome everyone today. This is going to be, I think, kind of a fun session. We don't have really a overarching topic, but we're just going to be showing kind of some of our favorite, most interesting cases. Some of this will just kind of be show and tell. I think some of it will also try to sprinkle some pearls in there as well as we go through some of these cases. So my first case, so this was a 7-year-old came in with abdominal pain. They just got an abdominal radiograph. We can see looking at the stomach, this was initially read as just gastric contents, but the clinician called us. They said, this patient had been NPO for about 8 or 9 hours at the time of this radiograph. Are you sure that it's really gastric contents? At that point, we said, could be something like delayed gastric emptying, could be a Bezoar. We're not really sure what that is, but, we wouldn't expect to see that much stuff in the stomach that far NPO. So we suggested an ultrasound to get a better look at that. So the couple images that I have here of the left upper quadrant, we can see a portion of the spleen, portion of the liver. At first, our sonographer was like, I just think there's a lot of air in the stomach. I'm not really sure I see anything there. But just with how densely shadowing this is, it's kind of suspicious that there's something underlying there. So we decided to, in order to prove that and get a different look at it, we just had the patient drink a little bit of water just to get a better look at it. This is a still image here. We can see there's this very kind of densely shadowing mass. It looks like it's in the stomach. Adjacent to that, we can see some of the water that the patient drank, and we can see all these kind of strandy, tendril-looking things. The sitting clip I'll play for you as well. Again, we can see all that, what looks like could be hair next to the that more densely echogenic thing. So this was a Bezoar. Patient subsequently had a CT at the request of surgery just to get a different look at it, just to prove that was actually there before they went into surgery. So this is just something I think you have to be aware of. This can mimic air in the stomach, but it really helps, I think, to have the physical exam. I told the sonographer to go feel around on the patient's stomach, feel if you could feel anything hard there, which she said she could. So she was palpating this big mass here. So this was a case of a Bezoar. Have a kind of interesting companion case to show you as well. So this was a patient that came in with a palpable epigastric mass, had a very similar looking, very densely shadowing echogenic thing that was in the epigastric region. We can see some of the layers of the stomach here. So this was confirming that it was actually intragastric. As we scanned around a little bit, we could see this other, what looks like an intussusception within the left upper quadrant. We can see some of that echogenic material within the central aspect of the intussusception. And this image on the bottom right here just have showing you that there's what looks like some pneumatosis in the bowel wall as well. I have a couple cine clips as well. I was trying to figure out if this was all kind of in continuity with what was in the stomach and what was connected with that intussusception. So I told our sonographer to kind of go do what you would do for a malrotation volvulus scan to look at D3 and see if there was anything kind of traversing through the duodenum there. So as we play through this cine clip here, so we can see the aorta, SMA, we can see that third portion of the duodenum kind of traversing through there. We can see this echogenic material traversing across that portion of the duodenum. Then I'll play this other cine clip here. Again, kind of starting superiorly, we can see the duodenum coming across midline here. And then I'll give it a second to get down to the left lower quadrant. It gives a very impressive look to it. So as we get down here, so again, we can see all that echogenic material within the central aspect of this and a very, very long segment of intussusception. So this patient went to the OR, found to have as we suspected, a large Bezoar kind of extending from the stomach into the duodenum all the way into the jejunum with a very long segment of intussusception. So again, I think this is just something that you have to be familiar with, just kind of the sonographic appearance of this, that Bezoars can be very dense and shadowing, can sometimes mimic air, but just kind of keep this in mind. And then just kind of a interesting kind of normal companion case. So this patient came in with right lower quadrant pain. The sonographer said she saw these weird looking kind of tubular things in the stomach. I'll play the cine clip through as well. So we can see the stomach has all this echogenic material in it, has all these kind of tubular looking things. So we asked the patient what they had to eat. So this patient just had a giant bowl of macaroni right before they came in for their ultrasound. So nothing pathologic in this case, just kind of an interesting look at what normal macaroni looks like in your stomach. All right, next couple of cases. So these are a couple of kind of odd appendix cases. So this was a 7-year-old. He was nonverbal, had a history of autism, came in with two weeks of food refusal and abdominal pain. So in this first image here, so we can see the appendix. It has a very odd look to it. So we can see kind of dives down. We lose a little bit of the tip here, but just looks a little bit distended, just has an overall kind of odd look to it. On our compression images, we can see that it does look dilated, so it's a little bit over a centimeter without compression, about 8.5 millimeters with compression. So it doesn't really compress a whole lot. We weren't really totally sure what to do with this, so we suggested they get a CT. So CT, I don't think was really all that helpful. So the appendix, again, has kind of a funny look to it. It's very hyper enhancing. It's, again, pretty large in diameter, so about 13 millimeters. So this was by the time we had gotten the CT, they had subsequently gotten this patient's labs back. So we can see they have a very high white blood cell count and then also a high percentage of blasts. So this patient ended up having a diagnosis of leukemia. So this was just a case of leukemic infiltration of the appendix, just kind of had an odd presentation just because of his nonverbal and just kind of had an odd presentation. So surgery, thankfully, did not take this patient to surgery based on our imaging. It just didn't really fit with his clinical history. But again, just kind of an odd presentation of leukemia. So main teaching point in this case, I think, is just to be familiar with this idea of lymphoid hyperplasia. So this is from a nice article that was published a few years back. So this is the normal appendix. So the main thing that these two arrows are showing here is that lamina propria layer. So kind of this hypoechoic layer is representing the lamina propria. So with lymphoid hyperplasia, that particular layer gets very thick. So if I go back to our case, we can see that the lamina propria, again, being this kind of hypoechoic layer, here gets very thickened with lymphoid hyperplasia. These patients can be a mimic of appendicitis. So this particular paper, so they said that if you have a non-compressible appendix that's 6 to 8 millimeters in diameter, but the lamina propria is more than a millimeter in thickness, that's kind of characteristics of lymphoid hyperplasia. So the way to differentiate that between true positive diagnoses of appendicitis are to look for those secondary findings. So we can see in our particular case, they didn't really have a whole lot in the way of, periappendiceal inflammatory changes. All the fat around this looks pretty clean. So you have to really think about those secondary findings. This is probably, in our group, probably the most common kind of false positive that we call appendicitis, or patients that end up being lymphoid hyperplasia. So just kind of keep that in the back of your mind. If you see an appendix that looks a little bit dilated, but doesn't have a lot of these secondary findings, look at that lamina propria layer, take a look at that and see if that looks thick. Can potentially make this diagnosis of lymphoid hyperplasia rather than calling it appendicitis. And Judy and Haitui, feel free to jump in if you have any additional comments.
I have a dumb question. Please don't judge me. I know I should look this up. I remember learning that lymphoid hyperplasia could cause acute appendicitis. It was like one of the more common causes. What's y'all's experience with that?
I will say I definitely seen this lamina propria layer be thick with acute appendicitis. I would say it's pretty often that we will see that. So don't hang your hat totally on that thickening of the lamina propria. So I don't know if that is necessarily representative of lymphoid hyperplasia coexisting with appendicitis, but at least in my experience, it's quite common that true appendicitis cases do have that thickening as well. Actually, I don't know if you have any other.
Yeah, I think I don't know if it was like published by one of my former colleagues at TCH, but they did find that there is increased incidence of appendicitis in lymphoid hyperplasia. And I think the thought is that, because there's luminal thickening and narrowing, so essentially sort of like a functional appendicolith or something like that causing the obstruction. So I think from their paper, it can lead to appendicitis, but that in isolation isn't really appendicitis unless there's other secondary findings. And so I still will call it just lymphoid hyperplasia, like basically normal appendix, if I don't see all the other things that you mentioned, Jeffrey.
All right. So my next case is the 5-year-old came with right lower quadrant pain, had a pertinent history of cystic fibrosis. So our first image here, we can see the tip of the appendix. So the appendix, again, just looks very odd. It looks a little bit larger than it should. The wall just looks a little bit heterogeneous. We can see in our compression image here, it's not super dilated, but it doesn't really compress a whole lot. It's about 7.2 millimeters without compression and right at 7 with. Then I'll play through the cine clip here. So the appendix is kind of right over here. So again, we see all this interluminal material within the lumen of the appendix. Again, this is kind of like that last case. The appendix itself looks funny, but we don't really see a lot in the way of periappendiceal inflammatory change or any other concerning findings. We weren't totally sure, again, what to do with this particular patient, so they went on to have a CT, which I have on the bottom left here. So again, it's not the prettiest image. I think the ultrasound shows the appendix better in this particular case. A little bit dilated, but again, the wall looks a little bit thick, but not really much in the way of inflammatory changes around it. So I think this is just an important one to be aware of, that the appendix can look odd in kids that have cystic fibrosis. So they get this kind of intraluminal mucoid impaction that fills the appendix. So it makes it dilated and also makes it difficult to compress it just because that intraluminal material is so thick. So this particular paper, they found that the mean diameter of the appendix in kids that have cystic fibrosis is on the larger side. It's about 8 millimeters. The biggest one they had was up to about 14.5 millimeters. Most of those, I think they had about 30 patients, and only 5 or 6 of them had compressibility of the appendix. So the vast majority will be non-compressible. So this is, again, one where you can't really rely on the actual diameter of the appendix. You really have to look at the secondary findings, see if they have that inflammatory change or any other things that make you more worried about acute appendicitis. But this is one you really have to know the history. If you know a patient has cystic fibrosis, just kind of keep that in mind, and don't rely as much on the diameter and the compressibility of the appendix. All right, and then one more appendix case. So this was a 5-year-old came in with right lower quadrant pain. So this was a totally normal appendix. So we can see that the appendix is not dilated, it compresses nicely. The base of it looks nice and normal as well. As we were scanning through, our sonographer very astutely noticed there was something else weird going on. So there was these kind of echogenic, kind of tubular looking things within the lumen of some of the bowel in the right lower quadrant. And I'll play this little sitting clip for you here. So we can see this kind of echogenic thing, and it looks like it's kind of slithering through the lumen of the small bowel there. So this patient ended up having a diagnosis of ascariasis. So these intraluminal worms, this is not something we super commonly see in Colorado anyways. So this was kind of an interesting case, not necessarily a specific learning point for this one, but just kind of keep in mind this is something you could potentially see.
I can't even look at the screen.
Yeah.
Really creeping me out.
I spared you from the Bezoar intraoperative images at least. So.
Yeah.
Thank you.
Yeah.
You're too kind.
I thought you were going to say pasta until it moved.
Yeah. All right, and then one more appendix case. So this is a 5-year-old came in with right lower quadrant pain. So this is again, very abnormal looking appendix. We all see all this abnormal inflammatory change, all this hyperemia around the appendix. We can see this big periappendiceal abscess. So we can see portions of the appendix right here. So as our sonographer very astutely noticed, there was this kind of abnormal looking echogenic linear structure that looks like it was kind of coming in to the appendix and kind of extending into that abscess next to it. I'll play through this sitting clip here. So as we can see here, so we can see that echogenic line right here kind of going into the lumen, and again, this very large periappendiceal abscess. So we kind of questioned whether this could be some kind of foreign body that was perforating through the appendix. I have a couple nice intraoperative images here, so I'll play through this little intraoperative video for you. So we can see this is that foreign body that we just saw. We'll see it come into view a little bit better here. So this ended up being what we were seeing on the appendix. So it had this very long kind of linear foreign body. So this ended up being a boar hair from a shaving brush, which some of you may not be familiar with. Some people use this for shaving. So this is somehow this child ingested one of these hairs and made its way into the appendix and kind of perforated through. So it's not something I've ever seen before, but sometimes we see those buckyballs or other things that can make their way into the appendix. You can get foreign bodies that get lodged there. But this was definitely a very unusual case that, again, we very nicely noticed on our initial ultrasound. Next case, so this is a young patient, a month old, that came in with concern for an inguinal hernia. So we can see what looks like a hernia sac here. And then the odd thing was that we saw these kind of echogenic, kind of nodular looking things that were extending down into the hernia sac. So this was with compression. So we can see that hernia kind of sliding in and out there. But we can see all of these very echogenic foci within that hernia. I'll play for you another sitting clip here. So I read this. I was very confused about what was going on here. I didn't know what these echogenic things were. I was wondering if, they could be fat. They look a little bit more echogenic than fat. So prospectively, I did not know what this was. Patient thankfully went on to have surgery. So I have a couple intraoperative images here, so we can see all of these kind of yellowish, kind of nodular looking things here. So this is kind of in the right lateral abdomen up near the colon, and then this is down in that inguinal region. So you can see all of these little echogenic, or not echogenic, these little calcified kind of yellow structures. Patient had a radiograph, so we can see some calcifications along that right lateral abdomen and down in the inguinal region. So this ended up being a case of a kind of meconium peritonitis that we happened to see some of those kind of calcified things on our ultrasound. So this is kind of theorized that these have, patients have an in utero perforation and have that spillage of meconium, then kind of subsequently sealed itself off. So again, this was just a very odd case. I wasn't sure what to make of it prospectively, but ended up having that meconium that just kind of made its way down into that hernia sac in the inguinal canal. And then my last case here, so this is a 4-month-old, came in with a prenatal diagnosis of ovarian cysts, so I had them picked up on prenatal ultrasound. This was her first presentation, just to follow these up afterwards. So this was, we saw in the right ovary this very kind of abnormal looking structure. So we see this very thick septation, some more cystic looking components. This looks a little bit more solid, but we don't pick up any flow within it. So they decided just to kind of follow this patient just to see how this evolved over time. So patient had a follow-up at 7 months of age. So it looks like that area kind of developing some calcifications within it. So the odd thing about this case was that our sonographer noticed that this structure seemed to kind of be dynamically moving throughout the examination. So this was initially kind of in the right adnex, so we would expect to see the ovary. And then as they were scanning, it kind of looked like it flipped the other way. So that kind of more solid component was more superficial. And as they continued scanning, you can see these images are now labeled left lower quadrant. So the structure kind of seemed like it was floating over into the left lower quadrant. Again, we can see some of those calcifications within there. So this patient after this ultrasound went to surgery just to get a better idea of what was going on. So this was that ovary that they are showing us here. So this patient had a congenital torsion of that ovary, and it basically just auto-amputated itself, and it was freely floating around the abdomen. So they went into surgery, and they could just see this structure, which is kind of dynamically just floating around. So again, a very unusual diagnosis. This was an auto-amputation of the right ovary related to in utero torsion. Right, so that is my last case. So I will turn it over to you, Hai Tui.
Those are excellent cases. Thanks for sharing them. All right, let me know if you guys do not see it or I just become silent or something.
We
Okay.
see you. Perfect.
Awesome. Thank you. So my first case is a 15-year-old female with 1 day of left pelvic pain. So already, in the left adnexa, you can see that there is a fairly simple but large, it measures 7.5 centimeters in greatest dimension, cystic structure, kind of gentle lobulations. So some kind of cystic structure. And I think you can partially maybe see the urinary bladder to the side there. And then you go and look at the ovaries, and this is the right ovary, which measures 10 or close to 11 milliliters. And then the left ovary is only 12. So there's not much of size discrepancy as when you compare just the volume. And, just be mindful that, I'm just showing some like 3 sample images, whereas in the whole study, there's like thousands and thousands of images and cines. So a lot of this information can be lost, and you can if you go through a bunch of them, you can basically pass by. But if there is, pain and there's like a large cystic structure in the adnexa, then the next thing you want to look at, aside from the volumes, which appears normal, is the vascularity or the blood flow. So here's the right ovary, which you would assume have normal blood flow, just like the normal low resistance. There's nice diastolic flow that's preserved. And then you can see the different scales too. So then if you're flipping through this really quickly, you can be like, oh, right. So, left ovary also has flow, which is fine because that doesn't really make it TORS or not TORS. But what you should notice is that it was kind of tough to get the flow. So the sonographer actually had to drop the scale down, use SMI or superb microvascular imaging, and then barely was able to get a waveform. And here the waveform is actually high resistance, whereas compared to the right, there is no flow during diastole. So all of that should raise your suspicion. And even though this image here looks pretty normal, that there is some kind of torsion. And of course, patient, because was in a lot of pain and there was a large cystic structure, they were taken to the OR, and this turned out to be an isolated fallopian tube torsion. So there was that peritubal cyst that we saw that was like 7 centimeters plus, and then the fallopian tube actually torsed around itself, and the ovary was fine in the OR. It didn't look ischemic or anything like that. So isolated fallopian tube torsions actually pretty rare and really hard to prospectively diagnose, just because the ovaries tend to be normal. There are times when you can actually see the whirlpool sign even on color images. And, looking back, we didn't really have a great whirlpool sign. Like, this is like probably the best that I can kind of surmise might have been kind of that twisting. Or other times where you don't really see all the other abnormalities, and this is a companion case, but you can see the actual twisting of the fallopian tube really well. And so in these cases, these are the direct signs that there is isolated fallopian tube torsion. So just be mindful of that entity. The ovaries can be completely normal, which, to me, I feel like ovarian torsion is already difficult to diagnose because of all the confounding clinical presentations. So let alone something where the ovary is completely normal. All right. So moving on to our next case, kind of similar regarding, just like gonads, but this is a male who was actually treated with ALL before and is in remission. And so he just presents acutely with 1 day of left-sided testicular pain. And this is the first kind of dual view of both the right and the left testis. And already you can see that there is maybe increased vascularity in some areas, and some areas are not. So the echo texture is already heterogeneous. And then here's some additional images where you can kind of see a little bit of like punctate echogenicities in certain areas of the testes, both on the right and the left. So of course, urology calls me up and was basically like, is there torsion? Is there epididymal orchitis? Like this seems like a very acute presentation for him. And I didn't think it was torsion, but we did image several times late, or like multiple times, because he kept coming back multiple days in a row, just complaining of said pain. But they always look the same. There's always colors in some areas or blood flow in some areas, and then some areas are absent blood flow. So there was high concern, and surgery or urology did offer to, just kind of do an exploration, but they decided to hold off on that. Eventually, they did do some bone marrow biopsies, which were negative, I think, in the beginning. And then 2 months later, they finally decided to do a testicular biopsy just because the pain did not resolve. And it turned out to be a late isolated relapse to just the testis. So that's why the bone marrow biopsy was negative. So I found this case to be kind of interesting because it was, so much workup was done over like 2 months period. And even though I think in my differential, because of the heterogeneous appearance of the testes, I actually did call relapse or, AOL infiltrative involvement, but the team was just not ready to kind of treat that patient with chemotherapy without later on confirming with a testicular biopsy. So I think in the end, when you do have these abnormal findings, you can give a differential, but ultimately I think they'll probably have to do biopsy, especially if it's cancer or tumor related, where they actually have to give like chemotherapy. I don't know if you guys have had some of these cases before, but I don't know. It was just kind of nerve-wracking because they just kept coming back and be like, "Are you sure it's not torsion?" And I was like, "Yeah, I think so." It's like my confidence start, dropping after like the 5th ultrasound. I'm like, "Oh my God." But anyway, so I think the call was correctly made, but it was just still nerve-wracking. Similarly, there's this patient who comes, but with a right side testicular pain. And his testis compared to our first or other case is actually nice, homogeneous. Blood flow looks good. And then here's the triangular epididymal head. But adjacent to that, there's kind of like this ovoid structure that's between the epididymal head and the superior pole of the testis. And here it doesn't look like there's that much blood flow, although you could argue that, the color box doesn't really focus on it. So maybe we're just not getting the blood flow. But when we did move it and have this ovoid hypoechoic structure kind of centered, it looks like there's a nice vascular pedicle to it. So I don't know Jeffrey and Judy, if you guys have seen this before. I've seen like one or two, but I'm thinking it might be like a torsion, detorsion of like a testicular or ependymal appendage, as opposed to, I don't think, I mean, this patient never returned, so it's for sure not like testicular torsion or anything like that, but mass wise, I don't think it was particularly looking like any kind of, paratesticular mass that's worrisome.
Yeah, no, that's very timely that you bring this up. I had an almost identical case yesterday that one of my other members of my group asked me about, and it looked very similar. Had this nodular looking thing next to the epididymis, and it looked bigger than we typically would see for a normal appendage, but it still had flow within it, like this one. He said, should I? He asked me the same thing. Can you have torsion, detorsion of a appendage? I have not seen that in the literature. I don't know if it exists. I don't know if Judy, if you've seen other cases, but I think that's probably my best guess of what these things are. When the appendage looks bigger than it is, these kids present with acute pain, but they still have flow within it. I'm on the same boat as you. I don't know exactly what to do with that.
I don't think the treatment really matters. I mean, as long as it's not a mass, you've excluded something like that. Anything that's pedunculated, I feel like can twist and untwist, as it sees fit until eventually it cuts its supply off completely and then becomes ischemic and breaks off. So either way, I don't think the treatment changes. Just supportive therapy for clearly testicular pain or scrotal pain, I should say. I think that's the best diagnosis for sure.
Yeah,
And would you
that's kind of
guys
what I said
recommend?
yesterday. Was like, we know it's not testicular torsion, we know it's not a mass, so it doesn't totally outside of those two things. That's really the main things we're worried about. So even though we don't know exactly what it is, I think that's a good theory that it could be a torsion, detorsion, but I don't think we necessarily have to perseverate it on it too much, just because, like you're saying, it's not necessarily clinically relevant.
Right. And then would you guys recommend follow-up just to make sure? I mean, it doesn't necessarily look like a worrisome mass, but is it still kind of like worth it to have them come back?
Usually patients can feel these once they know like where to look. And so I think just clinical follow-up is reasonable unless something changes like on exam or, pain level or something like that. That's my thought anyway.
I agree.
Yeah, that sounds very reasonable. Okay, so moving on to the right lower quadrant. So this is 8-year-old female, 4 days of pain, but no fever. So what we see in the right lower quadrant, kind of over the area of pain, is this area of just echogenic mesenteric fat. But what's also interesting, unfortunately, we did not see or visualize the appendix. But there is maybe like an ovoid. It's not quite tubular, but there is some other density here, with like a thin rim of hypoechogenicity. And then try to put color on this. It looks a little blurry, because I can't remember if it was from like a cine clip or not, but it's a little blurry, but there's no true blood flow within it, essentially is the conclusion. And then this is what it looks like on cinematic images. You can see there's that kind of echogenic fat. There's some areas of hypoechogenicity kind of popping in and out, which I wasn't really sure what to make of that either, aside from maybe some lymph nodes or maybe a thrombosed vessel or something like that. But whatever this area is very closely positioned to the ascending colon. So we did a CT because the appendix was not seen, and there is, just kind of like fat stranding or echogenic fat. And it did reconfirm this kind of ovoid structure very close to the ascending colon with surrounding inflammatory changes. So I ended up calling this an epiploic appendagitis, and there's under that whole umbrella there, it's a intraperitoneal focal fat infarction. And I feel like the omental infarction is more common, or I've diagnosed more of those. But the reason why I went with epiploic appendagitis is just because of the relationship or the appearance, just like kind of ovoid, like sticking out like an appendage, right adjacent to the ascending colon. Normally with omental fat infarction, I see more of just the triangular focal fatty area on ultrasound without, anything underlining and without that like anechoic structure or rim structure. But I mean, technically, I guess it doesn't matter because it's all conservative treatment anyways. And all the risk factors are the same for all of these. And it includes obesity. So you can see that there's increased, at anterior abdominal wall fat, as well as mesenteric fat too, for this 8-year-old female, or any kind of, if these things are secondary, then any kind of prior surgery or trauma can cause these focal fat infarction. And then of course, it's all academic, but you just do conservative treatment, as opposed to if it was true appendicitis or something like that, where you actually have to go in. But I actually haven't seen that many epiploic appendagitis. So that's why I thought I'd share, since omental fat infarction seems to be more common.
Yeah, and I think that's a great case. And I've seen a few of those, and they invariably they seem to always go into CT. Whether we see the appendix or not, they have enough pain that they seem to oftentimes get CT. And I think this is a nice example that we can make this diagnosis on ultrasound. Like you're saying, I think that differentiating the epiploic appendagitis and omental infarct can be. I agree. This one, has that kind of focal rounded area. I think traditionally they say like omental infarcts are more common on the right, and epiploic appendages they're more common on the left. But I think I kind of agree with you. This with how rounded that looks, it looks more like an epiploic appendage. But one of our audience members commented, are there epiploic appendages on the right side? I'm not sure. I assume they were kind of along the entirety of the colon, but I think classically they say that's more often on the left. But I agree, this one to me it looks like one.
Yes, so I looked it up too, because I was like, made sure that I called something that does exist. And yes, it can exist on the right side. I did check. It sometimes they said that the cecum itself can be void of it. But I did feel like this was a little bit higher than the cecum too, so I confirmed that. Yes. All right, so now we're going to move away from the body a little bit and down to or towards the extremities. So this is a 3-year-old female with right knee swelling. Interestingly, no limp, no fever, no limited range of motion. And then when we interrogated a little bit more about, just any kind of history of trauma, the parents were like, well, she did throw like a temper tantrum and then was writhing on the floor. And I was like, that's every child. But after that, they did feel like there was a little bit of swelling. So, was it trauma induced? I'm not 100% sure. I just feel like that doesn't seem like the typical trauma. But when we did image, you can see this is a longitudinal view, and this is the suprapatellar recess. There is this large effusion that's fairly complex. And then this is just the left side for comparison. You can see the patella. Here, it was just so big that we couldn't even include the patella within the view. For the non-compression and compression images, you can see that there is compressibility. So whatever this content isn't like a really hard mass, solid. It does kind of move and slush around. And then, of course, with anything that appears sort of solid, you want to put color on it. And there is no color within or blood flow within the mass, or, whatever the soft tissue stuff is. But around it in the periphery, you're able to get some vascular flow. So maybe there's a little bit of like synovial thickening or reaction, or maybe just like a normal blood flow to that area. But because of these, I did mention that these are likely to be rice bodies, which was weird because the ED physician said, this has been ongoing for a while, doesn't really cause her any issues, no other findings of, inflammatory changes or anything like that. So they were actually kind of asking me to kind of like help them triage, like, should I consult ortho or should I consult rheum? But I think ultimately we went with rheum just because there's no fever. It just seemed really benign overall, like it's not a septic arthritis. So then months later they saw rheum, and then rheum diagnosed them with oligoarticular JIA, just because this was the only joint involved. There wasn't really anything else going on, but it was interesting. So yes, you can see rice bodies, and when you do, they kind of look like that. All right, so now moving on to another joint. So this is a younger child, 22-month-old female with left shoulder pain. And this child, different from the first one, did have limited range of motion, and inflammatory markers were elevated. So the sonographer imaged the left shoulder, so the side of the pain, and then at first there weren't really any cine clips, but there was a still image, and the sonographer did note that he, like the soft tissue here looks a little abnormal, and so I asked for a cine clip kind of to re-interrogate that. But so on the cine clip, you do see that soft tissue abnormality, but then also the underlying bone just did not look normal to me. So this is the contralateral side, which is normal. You can see the smooth cortex, a little bit of irregularity of the metaphysis and the epiphysis, but that's normal because the cartilage is overlying it. But here it just looks like there's a break, and it looks very heterogeneous. And then so as you keep going and going, we did not see a joint effusion, which was kind of what the initial order was for, but you do feel like there's a cortical break, as well as, just some kind of like collection, a hypoechoic collection kind of in the subperiosteal region. And so we keep going, and then that collection becomes a little less hypoechoic, maybe a little bit more complex. And then, sorry, you might go back, and then here's another look at that soft tissue abnormality, and then just more of the more normal looking bone, but still that subperiosteal collection. So because of the, elevated white count and everything, I said this was essentially going to be osteomyelitis with subperiosteal abscess collection, and maybe even intramuscular or collection. And they went on to get an MRI, which basically confirms all the findings. And in the OR, they did note that when they were trying to debride it, there was a fracture, and they called it a pathologic fracture, and I wasn't 100% sure if that fracture was what I was seeing with the cortical break, or it was a different fracture. It was kind of hard to tell from their description. But either way, the bottom line is that, there was an abscess that needed to be debrided. And the patient did have bacteremia, and then everything else was confirmed. So I think ultrasound is actually a pretty good modality to look for not just joint effusion, but also subperiosteal collections, especially in these younger children who may not be able to get like the MR right away or without sedation or anything like that. But of course, ortho will always probably want an MR. This is a 6-year-old, so a little bit older, and with shoulder pain and swelling after falling on the ground. And so they had an ultrasound first, because I guess the swelling was actually visible and palpable. So we got this ultrasound, and this is the arm, the proximal humerus in long. So here's kind of that normal smooth cortex, and then all of a sudden you see this like almost like a mound of ossific density that's kind of like undulating. And then if you look carefully, there's kind of that hypoechoic rim on top of it, and then the muscle and everything kind of like being pushed anteriorly. And then this is what it looks like on trans. So similar, just kind of like that undulated appearance, and then there's almost that cartilage cap on it. So this is very typical or classic appearance of an osteochondroma. And I'll let you see how the cine looks. And so this is, once again, that bony protuberant that we're imaging, and then you'll see that cartilage cap, and you can even measure that, and then you're back to normal bone more distally. So that's just kind of going from top to bottom or cranial to caudal. And then, of course, you can always confirm it with a radiograph, and these can be easily followed. So sometimes, you start off with ultrasound first, and that's all you have. So you should be familiar with what osteochondromas look like. And I've seen these in like ribs and, different things where you tend to start with ultrasound just because there's a palpable abnormality, and that's what you get ordered first. So just kind of be wary that that's what these osteochondromas can look like. And then that's it.
Yeah, I think that osteochondroma is a great case. We've seen a couple of those, and especially for sonographers or for radiologists who aren't as used to looking at those on MR, that cartilage cap can be really quite thick, and like in your case, it can be very anechoic. It can look like fluid and can confuse people for fluid collection. So, and we see that elsewhere in the body. Sometimes with looking for hip effusion, some people get confused by the femoral head, the unossified femoral head, and it can be very anechoic, look like fluid. Just kind of keep in mind that cartilage can look like that. It's an interesting case for sure.
Yeah, cool. Great cases. Okay, I'm going to share my cases next. Hopefully you can see. Some of these are going to be great companion cases to what we just saw. So this was I need to get this out of the way. Go away. A 5-year-old, and the only indication we got for this ultrasound, so let me back up. All of these cases are actually very recent. So some of them I don't have like the pathologic diagnosis yet, but it's I'm on call all weekend and all weekend. These are cases that have come up. So this is a very real situation. Unfortunately for us, we really don't get very great history aside from pain, or they'll just like click whatever drop down option for an indication for the study. So hi Twee, I'm so glad you showed your case. So this was a kid who they ordered it was like the female right lower quadrant pain ultrasound. So a female pelvis plus appendix ultrasound. And right away, the tech noticed that the fat is abnormally echogenic. So some sort of inflammatory something is going on. There was a little bit of free fluid up near the gallbladder at the like gallbladder fossa near the tip of the liver. Not particularly vascular when you put color Doppler flow on it. Our techs are just amazing, and they did find the appendix posterior to this inflammation. So we did not think this was mesenteric inflammation related to a primary appendiceal inflammatory process. And on the cine clip on the left side, you can see it is sort of a triangular, sort of localized hyperechoic, abnormally echogenic focus of fat. And then there was a little bit of also, in addition to that perihepatic free fluid, there was some free fluid in the pelvis, not a ton, but maybe a little bit more than we typically would see physiologically. So we were concerned there was some sort of inflammation going on, not related to the appendix. What was interesting about this case and why I wanted to bring this up is, so most of our CTs for abdominal pain are imaged at an outside institution, and then they get sent to our children's hospital as a referral. So one day before any of these images, ultrasound images were obtained, you can see this classic look of omental infarct. So circumscribed fat stranding right near the cecum, between the kind of cecum ascending colon region, which is a classic location for an omental infarct. But the reason I'm asking you guys your opinion on this case is, why did we do the ultrasound in the first place? So, do you guys have any protocols at your facilities that if a patient has had a CT, do you require that be looked at before you will do an ultrasound? Or, so I'll tell you, I didn't even know there was an outside CT when I read our ultrasound. From a policy standpoint, have you been successful in reducing any sort of ultrasounds after a diagnostic quality study has already been done elsewhere?
Yeah, I think it varies. So like overnight, probably unsuccessful because, it's just the overnight workflow. But I think during the daytime, if I just speak to surgery or whoever that's requesting it directly, it doesn't, they usually don't push for it, if I can say, hey, but they will ask us to do overread. So if
yeah,
that's the case, we would have to overread that, diagnostic CT, which is fine. And then, so I guess, you either scan again on ultrasound and dictate that, or render an overread.
Yeah, we're similar. I would say we're not quite that organized. Oftentimes it takes some time, it seems like always once these get requested to actually get everything kind of organized as far as getting an overread done on the CT. So oftentimes the ultrasound's already been done, and then we become aware that a CT was previously done and requested. I would say our main layer of kind of recognize these is probably with our sonographers. I think they're pretty on top of things as far as they do a good job of looking at the history when they see an ultrasound request, and they'll often be the ones that notice there was a CT done, and they will ask us, do we really need an ultrasound? This patient had a CT that showed these findings, but we don't have much formal in the way of policies that I'm aware of that would catch these things.
Interesting. Yeah, because we could have saved this patient. I don't know how many hundreds of dollars do we charge for an abdomen limited and pelvis ultrasound? I just feel so bad for the patients sometimes. One other interesting thing, on the CT, the appendix was retrocecal, and on our ultrasound, it was not, which was, I guess that makes you even more confident that it's a normal appendix, that it moves location. But I was very surprised we actually saw it after I saw the CT. So, hi, Sweet, you already covered all of this.
No, but actually from that image that you showed, like on the ultrasound, without the stitching, without everything, like, would you be confident to say that that's not appendicitis? Because it's almost like the appendix and then like all this like inflamed fat next to it.
Yeah, the appendix. So I didn't include the measurement. It measured totally normal. She definitely had tenderness there because she had an omental infarct, but like the appendix itself looked pretty normal. Like it wasn't thick wall. There wasn't like fluid right by the appendix. All the fluid was like in the pelvis and then a little bit superiorly. So I felt confident. I'll be honest, I wasn't exactly sure why there was such focal inflammation on just the ultrasound. Obviously the CT was like super obvious. And I was like, oh yeah, duh, mental infarct. But yeah, I was pretty confident it was not from the appendix. But
Yeah, and like on that image you're showing there, I really try to figure out, exactly where the inflammation is centered. Like I feel with with the appendix, like on the deep aspect of the appendix there, the fat looks relatively normal as far as I can tell. Sometimes we don't get as good quality imaging down there on the deep part, but as far as like truly calling it periappendiceal inflammation, I try to really localize exactly where that inflammation is centered. And I agree, like this one doesn't, at least to me on this one image, doesn't look like it's centered at the appendix.
yeah, it was all anterior. So good point. Okay. This was another case from this weekend. So this was a 4-year-old male who was recently diagnosed with flu, forget if it was flu A or flu B, and then he had abdominal pain. And this was actually the second ultrasound we had performed within a 24-hour period. So initially, somebody thought this was very fluid-filled colon. And I appreciate that I'm not showing you all of the cineas of the abdomen, but I assure you this is not colon. It looks like these large locules of fluid containing low-level echoes. They were definitely mobile. And then there was a little bit of anechoic free fluid adjacent to these large globules of fluid. Another view looking in the sagittal plane. And as we're going lateral to medial, you can see not only are these locules of echogenic fluid present, but then we get into these dilated loops of fluid-filled small bowel. And so you can see the plica to know that it's a loop of small bowel. And I thought it was kind of interesting that the content of the small bowel really looks kind of similar to the content of these locules of echogenic fluid. One more cine, this is of the left side of the abdomen. And one point I also wanted to make about this is this cine, if you compare the image quality of the bowel wall, the intraluminal content of this compared to this prior cine, the detail is just so much better. So these first two cines were taken with like a superficial small parts preset where you have nice high frequency. The settings are just much more optimized to showing you this detail as opposed to this, which was, I think it was an abdomen preset. So when you're trying to look for detail, like what does the wall of the bowel look like, yada, yada, try that small parts preset. For us, we've had a lot of success. Just it makes further optimization of your images better. So this patient, because of the small bowel obstruction, because the clinical team was very concerned, he went on to have a CT. And you can see that the CT confirms that there are some abnormally dilated loops of small bowel. I'm not ashamed to admit I was very confused because I was like, well, this looks just like ascites, right? So it goes all the way down into the pelvis, this free fluid. It's kind of weird that there's some mass effect. And so I did not do a great job of putting the ultrasound pictures together with the CT pictures to kind of come to a coherent diagnosis. it did on some of the images look like there was some swirling of bowel, like maybe there was going to be a little bit of a segmental volvulus, not midgut volvulus, because we knew this patient's midgut anatomy rotation was normal. But because of this patient's obstruction, he went to the OR, and I love my clinical colleagues. So this was what they found in the OR. There was no volvulus, but there was like tethering of bowel. Our best guess, we're still awaiting path, is that this is probably a macrocystic lymphatic malformation that had a little bit of either bleeding or proteinaceous debris from maybe a little bit of a superimposed infection. We see this pretty commonly where there's like, you know, an underlying lymphatic malformation and then some like minor trauma or something happens and it either bleeds into itself or becomes infected. And that's when the patient presents, typically at a pretty young age. Just a reminder, these are not called lymphangiomas anymore. The International Society for the Study of Vascular Anomalies calls these lymphatic malformations. They can be microcystic or macrocystic, depending on the size or a combination. Typically, the treatment is sclerotherapy. Of course, this patient presented with a bowel obstruction, and so they took this out. There is a differential duplication cyst. It didn't really, the walls of this didn't have a great gut signature that like triolate the like 3-layer appearance of a bowel wall. So it could be a mesenteric cyst, just a multilocular cyst, but we are awaiting path on this. The next case, we've actually seen a couple of cases of this lately. I guess within the past few years, not super recently, but this was one of them. So this was a 10-year-old female who presented with right upper quadrant abdominal pain, vomiting, and our indication was rule out gallbladder, liver, or appendix etiology. And so the first image is a transverse of the liver. You can see the IVC and hepatic veins are big. This image on the right is showing you an abnormal gallbladder. It contains sludge. It's thick-walled. There was ascites on exam, and my baller sonographers, they're so amazing. They found a normal appendix. So the transverse appendix is that top right image. The sagittal plane appendix is the bottom right. And this was our cine. So we routinely do transverse and sagittal cines of our liver. You can see those big hepatic veins, big IVC. There was a right pleural effusion, but pay attention to this heart. Number one, the chambers are too big. Number two, there's really not much in the way of cardiac contractility. So a hypokinetic dilated heart. So immediately the sonographer came to me and said, I don't think that this is the liver primary etiology. And this was the patient's chest x-ray later. So we've had two recently where it's a patient who acutely presents with cardiac failure, but their presentation is not any sort of cardiac symptoms. It's probably related to like a congestive hepatopathy type thing. So they present more like a hepatitis type picture. This is reported in the literature. So especially in a kid that the sonographer comes to me and says, this is a sick kid, like something is wrong with this patient. I always on their cines will kind of pay close attention to the heart and see if first of all, I'm not an echocardiographer, I'm not a cardiologist, but there are some major things that we can diagnose as radiologists. We've seen this twice now. Okay, now going on to some more companion cases for Haitui's fabulous cases. This was an interesting case because of the history. So this was a 6-year-old male who just got a vaccine into his deltoid muscle, and then he felt a lump after his deltoid vaccine. So we went into the case thinking, you know, like, is this going to be a hematoma, some sort of weird fluid collection, you know, granuloma or something after the vaccine? But this is super heterogeneous, very large. This is a panoramic field of view to show the extent of this abnormality. Let's see if the cine will play. And you can see the, so we're going superior to inferior. There is this very heterogeneous lesion arising from the humerus because we're at the level of the deltoid. Going superior to inferior, you can see the, there's like this just large mass-like, very heterogeneous appearance arising from that humerus muscle, and it does cause mass effect on that overlying deltoid muscle. So we were very concerned this was going to be, I thought it was going to be a Ewing sarcoma. At pathology now it was an osteosarcoma. This was just interesting because this presented first with ultrasound, which of course we're going to see sometimes. So very aggressive lesion at radiographs with that on T1 non-fat sat and then stir image coronal, both of those planes where you can see that sharp demarcation of the marrow infiltration from osteosarcoma. So we can obviously see infection. We can, see all sorts of things. This ended up being osteosarcoma, just presented first at ultrasound, and then he actually went on to biopsy before he got radiographs and MR. Okay, this is my last case. So this was a patient who was sent to us from the ED, a 4-year-old with left peritonitis was the indication. And you can see this left parotid gland. Actually, I have 2 more cases. The left parotid gland looks pretty normal, nice and homogeneous. There are a few little lymph nodes inside of it. But then as you go inferiorly, there's some sort of weird calcification or something going on, like over that cheek region. So here we're going superior to inferior in the transverse plane. So we start out at the parotid gland going inferiorly, and there's something that is exerting mass effect on the parotid, not the parotid itself. The parotid itself looks pretty homogeneous, but there's like this weird sort of spiculated almost look of this mandible underlying the parotid. And so there's also a couple of lymph nodes that we can see in there. Like at the same time this ultrasound came through, like as we're reading it, we also got a request to look for a hip effusion in this patient because he also had a limp. So both hips are a little bit abnormal, just a little bit of trace fluid, a little bit of capsular thickening bilaterally, but not a huge amount of fluid. The metaphysis of that right humerus femur, we're at the level of the femur, looked a little bit not smooth, a little bit lumpy, bumpy. And on X-ray, I think it's also a subtle finding, but you can see there's very subtle sort of periosteitis along the greater trochanter on that right side, and the left almost looked a little bit lucent. So putting it all together, this was a case of neuroblastoma. So he presented with cheek swelling because there was osseous involvement, unfortunately, not parotid involvement. His primary was the right adrenal gland, and then you can see this MIBG, lots of abnormal bone marrow uptake, including MIBG uptake in that primary right suprarenal region. So, I always am like, when we see something that's concerning, neuroblastoma is always in the back of my mind with these young kids with limp or weird bone lesions. Like, should we just go ahead and add on a retroperitoneal ultrasound? Like, go look for the primary tumor and save some time with workup?
Yeah, that's a really good thought. Like, but then I feel like they would still order a CT or MR.
Yeah,
So,
for staging for sure.
for staging, yeah. But so I feel like it's probably, because that's my first thought too, when I saw the spiculated appearance of the mandible, I was like, oh, this is neuroblastoma. And then I think like at that point you would just like direct them to, like the other workup and maybe abdominal radiograph to see if you can see the calcifications. I don't know, whatever that's minimally invasive to start if you're not that confident that there's like metastatic disease.
Yeah, this kid, because of his limp, actually went on to pelvis MRI first. So there was a little bit of a delayed diagnosis just because of the way he presented. And we've had several cases that in the back of my mind, I'm like, is this neuroblastoma? And of course it ends up being neuroblastoma. And I just wish I would have just gone and found the primary mass right off the bat. Of course, when it's me scanning, not a tech, just ordering something or adding something on rather.
Yeah, because I wonder if were you able to see anything on the scout images?
Oh, on the localizer images? I think that they cut off
okay.
at the pelvis. It was just like diffuse marrow abnormalities. Yeah. It wasn't a long delay. It was just like, a couple days, but. Okay, I want to show you one more case because I want y'all's opinion. This was a 2-year-old, and the question from the ED was lymph nodes. And I feel like I see this all day, every day, billions of cervical lymph nodes, especially when there's like, URI time of year. It's like, yep, it's a lymph node. Is it lymphoma? Probably not. It's probably reactive. Follow it up. But this kid, obviously we found lymph nodes. On the CT, of course, we saw cervical lymph nodes. But the CT indication was different from the ultrasound indication. The CT indication was pain, fever, limited range of motion of the neck, concern for retropharyngeal abscess. So of course they went to CT to look for the retropharyngeal abscess, which we did not look for at ultrasound. We just saw these big lymph nodes that they asked us to evaluate. And of course we were like, no, there's no fluid collection. There's no necrosis in these lymph nodes. But do you routinely, when you're looking at these reactive cervical lymph nodes in young kids during viral respiratory season, do you routinely do like a peritonsillar look at the lymph nodes? You make your depth a little bit deeper to be able to see potential fluid collections in the deep spaces like this?
It's yeah, same. I see Hi Tweet nodding her head now. Yeah, we're the same way. We don't have it as part of our formal protocol. We actually had a really similar case not too long ago. It was like I want to say 16-month-old kid that came in with the, same indication of, cheek swelling, look for lymph nodes. And the sonographer that was scanning happened to have worked at a prior place where they did more tonsillar ultrasound than we do. And, it's pretty easy to look if you just look at the submandibular glands and just look a little bit deeper. And the kid had even a bigger or a peritonsillar abscess than this one. And you could see it really beautifully on ultrasound. They did not have any clinical suspicion. In a kid that young, it's really hard, I think, clinically to differentiate some of these things. So I don't think it's a bad idea to, it's kind of like we always say with, bulbulous ultrasound, you see what you know. And I think just raising awareness that you can see the tonsils on ultrasound and, if there's any clinical suspicion, I think it's a pretty minimally invasive way to go look at them. So I don't know if you have other opinions, but I think it's something that it's definitely much less, costly, more time effective, no radiation as compared to a CT. So maybe it is something we should be doing more often.
Yeah, I agree. I mean, we don't do it enough, I feel, because maybe it's something that we're not used to and we don't know. So
Right.
it's definitely an area where I think we can potentially add value, especially if there are, chunky lymph nodes and you can kind of go searching.
All right. It's part of our protocol already to look at the thyroid and just make sure it's there, especially in older kids where it might be PTC lymph node, like metastatic lymph nodes from thyroid cancer. So maybe we'll just add a quick CINA, like level 1 with a nice deep depth.
Yeah, I like that idea.
Let's do it. No.
I'll report back.
Yeah. We can
All
we
right.
can publish it. Okay.